So we talked about the components, right? You got an implantable pump. What's the cord that comes out? What's the name of that thing? Dragline. What's it connect to?
The controller.
And what's the controller need?
Power.
Electricity.
Would you please?
Yeah, really, come on you, Mr. A+.
Love that guy.
He's a physical terrorist, man.
Alright,
What makes
so
you do
let's
it?
talk about the stuff, we talked about what's on the patient. And you can see, I like this picture, I mean, it's a little bit crude, but you can kind of see like how everything's going. So, right, the pump is on the inside, it goes to the outside, it's gonna connect to the controller. The controller needs 2 sources of electricity, only one to run, but 2 to be safe, right? And then that blue port, or that blue is for the data, and that's how, like, if I came to interrogate the dad, how do we do that? And then I can see, like, if she had alarms, or what are the ranges that she's flowing in and stuff like this, okay? Then, so there's a picture of the controller down here. You can see that she will have, and it's on her bedside table, a battery charger, okay? And, the battery charger is super easy, right? So the battery's attached to the charger the same way they attach to the controller. So you see the white arrow, yeah, okay? And it just connects here to the white dot. It clicks into place just like it does on the controller, and it's kind of counterintuitive the way this links over, but then it just sits there, right? And so, I don't have it plugged in right now. I can. And like I said, the batteries last about 6 hours, and for each battery, and then it takes, like, if it was fully depleted, like let's say it depleted all the way down to like near low, it'd take about 4 hours to fully charge. She's got 6 batteries.
Oh, cool.
Right? So she has plenty of batteries. She has plenty of batteries to just stay on battery all day, right? Or to be on and off from battery to wall electricity, okay? So one of the things I want you guys to get comfortable with, and what I'll have you come up and do in a little bit, is I want you to feel comfortable taking her off battery, or taking her off the wall and putting a battery on, and because this is what you'll do if she's getting up out of bed or she's gonna go have PT or OT.
Thanks.
Okay?
What's your appointment? Should we prepare a couple of batteries? Or?
Yeah. So we'll talk about that in a minute. She's got a bag with her. And sorry, that's on here. So every VAD patient is, when they're taught in the hospital, they are taught to always, whether they are walking out of their house just down the driveway to check the mail, or they're going to Target, or they're going on a trip, right? They are supposed to carry a backup bag with them. And what do you imagine the backup bag has?
Batteries.
At least 2 batteries. That's not my stuff, right? That's whatever you
No,
else.
no, somebody's phone, I think it's Dimitri's.
Okay.
You need to charge your battery.
He doesn't wanna hear. He doesn't
My
wanna hear
battery
it.
always charged.
Okay, so in the bag are at least 2 fully charged batteries, all right, and a backup controller, okay? Which we'll talk about that in a minute, okay? So if the patient is going out of her room for PT, what do you think you need to bring with you? The bag. The bag always got 2 batteries in it, right? And she's not doing a lot right now. She's a little bit of a slug, right? So I would, every day or so, those batteries don't lose. Like if this battery's fully charged and it's just sitting here, it'll sit here a long time without losing any, right? But if we're always using the same 2 of the 6, then you're like constantly just charging down the same 2. So it's nice to just kind of rotate through the battery. So like take the 2 and her bag out and put 2 more in there and then start rotating. You know what I mean? Does that make sense?
Yeah.
And that's usually what the patients do on their own machine.
You can only gauge how much battery is left by plugging it in?
No,
Or is there
no,
a
no,
button
no.
you can push to see what level it's on? Yeah, okay.
Battery fuel gauge, okay? So.
Even when it's unplugged.
Yeah, and there's 4, yep, even when it's on. So there's 2 ways to tell. There's also a battery fuel gauge on the actual controller. So 2 ways to tell if you've got a fully charged battery. You can hit this, right? And so 4 bars is about 100%. 3, 75, 2, 50, 1, 25, right? And if I plug in here, that will be fuel gauge same way. So you can see the fuel gauge on the face of the controller or on the battery itself.
So it's not charging from this?
Nope,
Okay.
nope. Only
That's
charges
nifty,
from
huh?
this. Yeah, that would be nifty, wouldn't it? Yeah, it'd be a lot more stuff in there. So it charges So this sits on our bedside table. If she's depleted a battery, taking a battery off, it's always a good idea to just put it back, set it back in the charger. It doesn't hurt or harm the batteries to stay sitting in the charger. That's fine. And then you'll see, like when I had that battery on there, ready is a green light, means it's fully charged, ready to go. The status, if it's yellow, right, it's charging. Okay, if it's red, it's either not plugged in there right or it's a defective battery. If you had a defective battery, just call me and I'll bring you the battery. Okay? And then here's the other thing I wanted to show you is there's a couple different ways you can carry the Heartwear. Some patients wear it in like in a waist. A lot of men wear it that way, like in a waist pack. She likes to carry this kind of little messenger bag style. So yeah, I was gonna take that. So this is a patient who we transplanted. So when we take this stuff out, I keep it so this is how it's gonna look when you see her this afternoon. Her name is Lynn. And you can imagine, you know, we take care of these patients for a long time, so we get really close to them for a long time. Okay.
And she'll be going home after this?
Yeah, she really wants to go home now. She's not really recovering from her stroke. Okay, so this is how Lynn's gonna be. Actually, she's wearing it on this side right now because of her stroke. She had a right MCA stroke, okay? So her bag's like this.
Where's the thingy bopper?
Where do you
Yeah,
tuck in like extra drive line?
Extra drive line.
Is it like something that's gonna have a loop that's hanging down?
So it's coming out, so imagine if I had a line coming out, like, right? And it's going in,
Going into that side.
right? So you do a couple things. So I'm bagging it up like this, so because this is what she's gonna be bundled up with you like. So a couple things you can do. Don't be afraid to look under the hood, right? Flip this open. It's a magnetic, right? So just flip this open, and then you can flip that down, and then you can see. So drive line, right? Drive line cover, right? This is just so it accidentally doesn't get pulled out.
What do we put the slack for the driveway?
It's coming out right here.
How much slack is there?
There's not a lot.
There's like this much.
Can we just slip it in the bag?
You shouldn't slip it in the bag because then that'll pull on her.
So we should just leave this.
It should be, yep. Don't
So does
slip
it just, how is it attached to her? Is it sutured in or?
No, not anymore. It used to be when it was new, and now it's got a dressing on it, and I'll show you about the dressing. Okay? So the drive light comes in here, right? She's gonna have 2 batteries on when she comes, okay? And the batteries sit down, like if I were to unzip this further, you can see that the batteries are sitting like this.
Okay.
So the reason why I don't have these batteries hooked in is because it turns this on, right? So I've got this so you can just kind of practice, but hers will be like this, and they'll be plugged up, right? So,
And then she gets here. And
so let's see, and you get her, and you do your assessment, and you talk to her and everything, and now she's like, I'm so tired, that was such a long trip from 4 to 6, in the elevator, in the bed, I really want to take a nap. And you go, okay. You're gonna take a battery off, and put her on AC. Right, well, oh, I'm not gonna do it because I'll turn this on, start screaming, right? Then you turn it on. Alright? Make sense? Okay. Now, how can I look on the controller and make sure that I'm getting electricity from the wall? Green light, green plug, right? And the device is always gonna pull from the wall, alright? So I'm just gonna hand this around like this, and when you can kind of see, and we're gonna talk about the parameters, but you can kind of see the screen through this little window. It's just kind of hard, but that's how she's gonna be packaged up.
So she's on the controller all night when she's in bed, sleeping,
Always on the controller.
always on the controller.
Always on the controller.
And this is only if she leaves the room?
No, that bag, it's like that all the time. Cause the bag is away, otherwise it would just
Well,
be
when is she on
like,
the batteries? I mean, is that just when she's,
she's on, so she's always on at least one battery, okay? So the available way you can do this is 2 batteries, or battery and AC, right? So,
In this case now, she's both batteries?
In that case scenario, she's both batteries, but
And getting out.
but the bag is always on her, so you're gonna be taking the battery off, and note to yourself, the battery's still sitting in there, right? So you need to like look down and see that, and that's why it's helpful to look at the face of the controller to see the battery fuel gauge, right? So if you see that it's down to 2, you're gonna take that battery off, pick it up, put it in the charger. If you want, you can put another battery in there, that's fine, and then you're gonna hook her to the AC. The bag is to keep everything,
I just
right?
can't remember from the other guy, the other system, that he wore the batteries
He had a
at night.
vest.
Oh, he had a
the
vest,
halter
yeah.
vest.
So we took him off the controller in the mornings when he went and sat in his chair?
Controller, they're always on the controller. You can't have the VAT on without the controller.
Oh.
So controller is always on, controller is always plugged in, controller is always with them, right? Because the VAT has to go to something, otherwise it's not working. So he was always on the controller, okay? And what you're going back and forth on is the electricity. 1, you're plugging him from the wall to battery, and 2, you're changing batteries.
So the 2 front ones are wall and battery both.
Interchangeable, yeah?
Yes,
Oh,
yeah, it can
okay.
be either, because the attachment for battery and AC is exactly the same.
And if I have it in the wall, I don't need to also have it on the battery.
Just
You
hide.
do,
I do.
you do, cause what if,
The
What
wall
if, you
becomes
know-
unplugged. we
what
put
if
the
Trump
battery
becomes
back.
president?
Yeah. It all hits
Just
the
kidding,
fan.
just kidding,
Yeah,
I
you-
love Trump. I know, I don't want this to be, okay, okay, never mind, oh, Trump. Okay, no, I'm just saying, what if you lost wall power? Okay, if you lost wall power, that's why this is sitting here. This is sitting here for just in case. Even if I have another battery, it's always gonna pull from the highest, whatever battery has the most, okay? And that other battery's not doing anything, it's just sitting there, in case this gets unplugged, in case,
Wake up, my canine
in
hearing.
case that gets unplugged, in case it wears out, in case anything,
So you
right?
either have the wall and a battery or 2 batteries.
That's right, oh, you're always gonna have 2, right?
Sorry, it's my patience.
No, that's okay, the only time you're ever gonna have 1 is when you're changing.
Don't you
So is
worry.
there a flow sheet that comes along with this, or we just, the nurses just
You,
document?
they've been narrative, but I
Narrative?
gave you a, like, what should you document
Gotcha.
in your shift?
Gotcha.
There's like a little paper that tells me what I need to write.
There is.
Did you say there's an
Love
extra
it.
controller?
What?
There's an extra
Yeah.
controller, just in case.
If we lost the wall power, let's say for a couple hours,
Yeah.
is it gonna be all the time?
Is it gonna do what?
Is it gonna be all the time?
If there's no wall.
Well, what would you do if there was no wall power?
Use the batteries.
Use the
Put
red-
another battery on it.
Or the red, oftentimes if there's no power, we have the red.
You have the red,
outlet.
every hospital has an emergency generator, right? It's more a question when they go home. If we had an extended power outage in the Bay Area, right, for 2 days or something, right? What we tell patients is just go to any hospital, go to the hallway, you don't even have to check in, right? Take your charger, go to the hallway, plug in, charge your
Right,
batteries,
yeah.
right, and then go home, right? So, if you lost wall power, you would take this off and put a battery on it. Just like if they lose wall power at home, cause they're gonna lose electricity at home, right?
Right.
The storm or whatever, right? Okay, that makes sense? Alright, so what you guys are responsible for, okay, I'll cover that at the end, because I haven't covered all the things you're responsible for yet. But in terms of this, you're really just responsible for making sure that she's got 2 sources of power at all times, and that you know which one she's on. That you should sort of know in your head, like, oh, she's on battery right now. Or, oh, she's sleeping, I put her down, like, she came back from PT, I went in, I looked at her, I gave her whatever, her medicine, and then I put her on the wall. I know she's on the wall right
I mean, you're always on the wall if you're plugged in,
now.
even if you've got a battery, correct? There's not like a switch that makes it go
Yeah,
to the
no,
battery.
you're always on the wall if
If you're
you're
plugged in.
sleeping or you're, right.
Is
Well,
there,
yeah, if you're plugged in, yeah.
is there, if you're on 2 batteries for too long, is there a low battery warning on? Okay.
Okay, anything interrupted, like boop boop, even this one we keep getting, right? That's, you get time, no worries, right? That is on, okay? If it's,
I'll start.
right, if it's constant and like that's VAD's off, okay? And what are 2 things I already told you can do to turn the VAD back on?
Drive line.
If the drive line's out, put it back in. If the electricity's out, put it back in.
In that order.
Call Albert.
Right?
And Albert has it all memorized.
And, and remember how I said is like the brain doesn't, like reading isn't something that happens when that kind of, when you're freaking out. So there's one thing I want you to do, and it's on the assessment thing that I'll give you, is every single, like at the beginning of your shift when you do your assessment, I want you to listen just like you're gonna listen to our heart, and you're gonna listen to what we call the LVAD hum. So you're gonna listen to that sound I had you do, and that's because then you always know the pump is on. Right, if you ever have any, like if you're just like, I don't know what this alarm is, I can't fix it, I'm waiting for the MCS team to call back, you know, she seems fine, but it's a very loud alarm. Listen, if you hear, that's on, okay? Whatever it is not that the VAD is on.
So do you actually hear an apical beat, or do you just hear the humming?
You hear the humming pretty much over, you probably can hear
Overrides, yeah.
some, but yeah, usually it is loud.
And on an EKG, will it show?
Yeah,
Okay.
the pump won't show, but a normal, it's having a normal electrical activity.
Okay.
Yep, so you can do the EKG and see
Interesting.
EKG tracing. Okay, okay, so, oh, I wish there was a dry erase board in here.
We have
There is one right here.
That's not there, that's, so I can play with you.
That's a demonstration, Dimitri.
It looks like
Did you
this.
need dry erase?
Michelle, do you want this dry erase
That's what it
board?
looks like. That's not here, that's
Yeah.
just,
Just put it down, Dimitri, just put it away.
Do you
that's
want
why I had to put it under your
Don't look
shirt.
at it.
Do you want this dry erase board?
Yeah, sure, I can, and I can do it over there.
Can you guys, well, no, cause you need to be on video, sorry. Can you, somebody bring that to the front for me? Like, one of the gentlemen, one of the ladies.
Yeah. Oh, I see, it's just,
Got
I
it.
thought, why is it looking just like that?
No, it's so I can
Okay,
play, you know, so I can show you.
I see.
Okay.
Thanks, guys.
Thank you, guys. Alright, so the fact that, remember when I said the pump is like, what's our pump like, our heart? Is it constantly going like a
Yes.
jacuzzi pump?
Muscle.
No.
No, it's a
That's relaxation.
Yeah.
Fills.
It fills and empties, right? We have a distinct filling or relaxation phase, and then we have a distinct contraction phase, right? So, we are pulsatile. Anyone do A-line tracings here? No, that's okay, doesn't matter, okay? So if I have a catheter
Can you use a
sitting,
different color?
sure.
Thanks.
We don't have any other colors.
No, she has brown.
Okay.
Thank you. Sorry, Michelle. That's good. No, that's good, Ram. Thanks.
If I have a catheter sitting in my radial artery, right, and I have it hooked up to a pressure bag and a transducer, and I wanna see what my blood pressure looks like on a graph, okay, it's called the A-line, right, this is what ICU nurses have. ICU nurses have it so easy, cause checking blood pressure for ICU nurse is this.
Oh, wow.
You guys got it way harder, okay, so, but the tracing looks like this, and what this is, so if we have, like, let's say this is 120, right, 110, blah, 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 down to, 40, okay, scale, and this is time, okay? When our heart beats, so right when the ventricles go and contract, that's the highest the pressure is in the circuit, right? That's the highest the pressure is because the LV contracting creates a big amount of pressure, right? And so we're gonna call that 120, okay? Millimeters of mercury. That's what we call systole, okay? Right? Then our heart is what's happening now. Now it's relaxed and the ventricle's filling back up with blood, right? This is cardiac cycle, right? This little notch we won't talk about, but it's the valve shutting, okay? So then, right when it's totally filled and it's just about to contract again, that's diastole. And so we'll call that 8. Okay? Right? And in the middle some here is what we call the mean arterial pressure, or the MAP. Okay? Right? Oh yeah, systole or systolic. There you go. Does that make you guys feel better?
Oh, no, it's
Systolic. There we go. And diastolic. Okay. Now the MAP, or the mean arterial pressure, is I'm going, so what we're doing, all of us in this room right now, we're going high, low, high, low, high, low, high, low, right? 120 over 80, 120 over 80, 120 over 80. That's what we're doing every cardiac cycle, every time a heart beats, right? And we need a certain map, or mean arterial pressure, or mean perfusion pressure, for us to be alive. And that map is 60, right? So we need, as human beings, a map of 60 or above, okay? And you need this to perfuse the kidneys, okay? So when, you know how like if someone's coding and they code for a long time and then they end up in renal failure? It's because they weren't getting enough blood flow to the kidneys, right? You need a blood flow to the kidneys of 60 millimeters or greater, right? And pretty much with the rest of our body too, okay? So the mean arterial pressure is the average between these two, okay? So this is how we're working. This is how we're getting blood and oxygen to our organs. High, low, high, low, high, low. Put a blood pressure graph and I can get the high, low, right? Yay, blood pressure, right? Okay, but if I took your ventricle, put a hole in it like an apple core, right? Like you saw in the video, right? And then I'm displacing 85% of the volume that would normally be in the left ventricle with a jacuzzi jet. The jacuzzi jet's going, right? The jacuzzi jet is not going, it's just going constantly, right? So what that is doing to the patient's native or natural pulsatility, it is naturally bringing this number down, and it is naturally bringing this pressure up, so that what you have, if we put the catheter in her artery and mapped out what her blood pressure would look like, it'd be more like this. Okay, and we'd still have the same, but she would have this map of like 70 or 90, right? Something over 60. Does that make sense? Now, what does that mean when you put a blood pressure cuff on her? You might get a blood pressure that looks like this,
Okay, so.
right? And you do not freak out,
92 over.
87.
87,
Okay.
right?
Close.
Now
That's
normally,
awfully close.
that is close. Now normally you'd be like, oh my goodness, the systolic is not 100 or over, right? So that's kind of like, any one of us would be alarmed as a nurse, right? To be like, you don't have it. But what if you Google right now mean arterial pressure and you put that in for systole and that in for diastole, you're gonna get a mean arterial pressure of over 60. Okay? So does that make sense? So is this an okay blood pressure for her?
Yeah.
Yeah. So she's got a narrow pulse pressure. And sometimes it gets so narrow that you can't get it with the cuff, okay? So the blood pressure cuff, the automated blood pressure cuff is looking for that high and that low, right? When it doesn't have it, it doesn't know what to do, so it reads error.
So how do we measure?
How do you? It's like you knew I was gonna talk about that. So how would one
Brilliant.
do that, right?
Manually.
Manually, who said manually?
I did, the old nurse.
The old nurse, I knew. I was gonna say, isn't that old nurse? Yeah, it is. Okay. Now, so what is a manual pressure?
Shout out to the old.
I know how to do them. I'm gonna get even better at the archive.
So
Yeah, but then the
important.
blood pressure comes, yeah, well, it is important.
Should we try the automatic first, and then if it doesn't work?
Yeah, because she's right now, she's going by, she's what we call pulsatile enough that you're able to get it on the automated one. So she's got one in her room.
Accurate?
Yeah,
Oh.
it's accurate.
Okay.
Yeah. Okay, so what you would do if you couldn't get it, so she's also getting dialysis. So on a dialysis day, right after dialysis, you may not be able to get it because they pulled a bunch of fluid out.
And so she's got low.
So she's got lower, right? So you may not be able to get it on the automated cuff. So what would one do? One would get, so there's two things you need, and I don't know if you have them here, is a little Doppler probe.
I don't think we have Doppler probes.
Okay, they have it on 4. I know St. Mary, I know you're technically not in the same place, but they bought one on the rehab unit for her. So it's just a little handheld Doppler.
Oh, have her come up with it.
Right. I can also drop one off. If you guys are having routinely not being able to get the blood pressure, I'll bring you a different setup, okay? So you just call me, I'll bring you. But so far she's been here for 2 weeks and we've been able to get her blood pressure on
Is she
this.
in our ICU or
Huh?
what?
No, she's in rehab.
Oh.
Okay, so what you would do is you'd have a, okay, so I'm gonna do it on you, right? Okay, all right, ready? You ready? Okay, so I've got my Doppler probe, right? And the first thing I'm gonna do with my Doppler probe is I'm gonna listen for her arterial pulse, right? If I put the Doppler probe on Dimitri right now, or you just had coffee, you're gonna be like, right? That's this. High, low, high, low, high, low, right? We're hearing the valve shut, right? That's what we're gonna sound like. But we're stealing blood away from her, right? And putting it in the jacuzzi pump, right? So we're gonna hear on her more like, so there is some pressure differentiation, but it's not like us, right? So you hear that sound, right? So you do a little X marks the spot. That's where I hear the sound. Then you put a blood pressure cuff on her that's got an old school sphygmomanometer. It's got the needle on it, right? Now, what I'm gonna do is I'm gonna put that on her. I'm gonna be looking at the needle, right? And I'm gonna pump it up to like 120, 130, above her systolic, right? And then, so all you're doing is obliterating the flow of blood through the arm, right? So I don't wanna hear the sound anymore. So I put the ultrasound back on my spot, because I've marked the spot, I know where it is, because I'm not gonna hear anything, or I shouldn't. Put it back on, I hear nothing, right?
So
Now I
play that one and then listen again.
And slowly deflate, watching the needle. Deflate, deflate, deflate. This is like 120, 110, 90, 80. Right when I hear the sound, I look at where the needle is. That's the map. It's just one number. My blood pressure is 87.
Change in the sound.
Okay.
Your blood pressure is one number and
One number.
Yeah.
for
Now,
example.
what she would do, like in the old days when you listened to it, you would hear two sounds.
Of course.
But you're not going to hear two sounds. Or you're just going to hear the return of blood to the radial artery via the ultrasound, right? You're just magnifying that sound for you. And that's the blood pressure. It's one number. 87. So your mean arterial pressure, or your pressure, your pressure, perfusion pressure is just one number.
And above 60 is.
Above 60 and lower than 90.
Okay.
So we want a map above 60 and lower than 90.
And that's the
And we
map.
want a systolic under 100.
So map, 60, 90, one number.
Okay. I'm gonna talk about, there's a lot of slides in here and I printed them off for you about all the different alarms and stuff. You just enjoy that reading. You just knock yourself out on some night shift,
Good on
okay?
John.
All right, but I want to talk to you about, okay, so we have the basic setup, right? You guys understand the basic setup? Okay. So what are the management, or the clinical management of her? So we have to still manage her heart failure, okay? Now she doesn't have nearly as bad heart failure as she did before she got the pump put in, but she still has like about class 2 heart failure. So she's still on a diuretic, right? And if you think about it, we're assisting the left. The right heart still has nothing. So we have to be really, like the VAD won't get any blood over into it if the right heart's not working. Does that make sense?
Will you repeat that one more time, because I got half of it?
The right heart has to work in order for the VAD to get blood,
Right.
right? So the VAD can only pump what it's got, right? If I drain the jacuzzi, I can't
Right.
do anything with the pump, okay? So it's the same thing. Now the right heart is unassisted. The left heart has a jet, the right heart is unassisted. So we still add, you'll still see medications on that's like babying the right heart,
Okay.
so that the right heart can still send blood over the left, okay? So we will watch carefully for volume overload on her, for basically increasing right heart pressures. So like signs of increased volume would be like all of a sudden her venous jugular vein, right, is jugular vein distension, right? Peripheral edema, right? All of a sudden it's a lot harder for her to lay flat because she's starting to back up or fill up with fluid for congestion, right? So she's on medications for heart failure management, and it's mainly to help the right heart keep the blood coming over, okay? Now, blood pressure management. You wouldn't believe it, but the number one risk factor for stroke in patients with this particular problem is hypertension. So it's even higher risk factor than having a subtherapeutic INR. All right, so let me draw you a little picture here. If I have, okay, so this is like if you cut me in half and are looking in, right? So this is my right heart, this is my left heart, and then here's the bad. And then the outflow graft. Right. So you have blood coming into the pump, right, and out into the aorta. Okay. Now, this pump is what we call, it's really afterload sensitive, meaning if the pressure on the outflow, right, it's sucking blood in and pushing out. If this pressure right here is really high, it's too high for the pump to overcome and it can't push the blood past it. Does that make sense? Okay? So, this woman that you're about to take care of, she is a chronic hypertensive patient from the beginning of time, right? That's part of what led to her heart failure, okay? And she had chronic hypertension as a VAD patient. And so what happens is the blood, if my blood pressure is this is way too high of a blood pressure for a VAD patient, okay? I mean, this is fine for you and I, but if you have the blood flow trying to get past this, it can't very well. Some of it does get past, right? So you have 5.5 liters per minute going into the aorta, but it's sort of eddying back around. And what is blood doing when it's eddying like that? Clotting. And then we've got brain right there, right? So she had a huge stroke, right? So we tried really hard to control, she had everything under the sun in terms of blood pressure management on. She had way more meds than normal VAD patients have on. And so she was managed and she did great for a while, and then she had a very large right MCA stroke.
Is this systolic cannot exceed a 110?
We don't even want the systolic to exceed 100, and she often does.
And so
So there'll be, there'll be PRNs. Right now they started lisinopril and it really bottomed her out, and she was actually having low blood pressure for the first time ever down on the 4th floor that we have here. But I think they're adding, so you'll have hydralazine that you can add on, but she's got everything under the sun. So you'll have call parameters on your blood pressure stuff. And so one of the things you're gonna be looking for, so management, right? You're gonna be watching out for volume overload or right heart strain, right? You're gonna be watching out for untreated hypertension. And that's gonna be a systolic over 100 or a MAP over 90, okay? So you're gonna note what the blood pressure was, okay? Because we're trying to keep her blood pressure under those limits to prevent stroke. Okay. Also to maximize the function of the pump, right? If the blood pressure's that high, the pump's not getting the blood out as well.
have they been taking her BP while doing activity down there?
I think they have.
Or is it just a rest?
I don't know.
Okay.
You don't get too mired down in blood pressure. Take it like you take it on your other patients, okay?
Yeah, well, I wanna take it maybe when she's doing something, see how it goes.
Well, your blood pressure is not gonna be a huge, you're used to looking at numbers to help you gauge how the patient's doing, and you're really gonna have to harken back. Oh, I'm sorry that the old nurse left, because it's a really old way to think about stuff, right? You're gonna have to go back to how does the patient present, right? Does she look like, is she diaphragmatic? I mean, right, what does someone with really, really low blood pressure present like?
Very
Baked.
Pale, they look like they're in shock, right? Diaphoretic and pale and weak, right? So, this is what I tell ambulance drivers, right? Because they'll call me and they'll go, I've got a VAD patient in the ambulance, should we fly? What are you talking about? Like, she sprained her ankle, number one. No, you shouldn't fly here. Like, she's fine. And I can't get her blood pressure. I'm like, well, what does she do? She's texting. So, right. So, but she's bossing me around at where to place the IV. Okay, that indicates a perfusion pressure over 60, right? Right, that's what, right? Warm skin, mentation, not, pink skin or, well perfused skin. Make sense? Okay. All right, so blood pressure management, heart failure management. Obviously, because you have the blood contacting a foreign surface, which is the inside of that pump, they have to be anticoagulated, okay? So she's on warfarin, and we keep her INR between 2 and 2.5, okay? And if she's below 2, we bridge them with Lovenox 40 sub-Q. So if it's below 1.5, it would be twice a day. If it's 1.5 to 1.9, it'll be once a day. And then if her INR is 2 to 2, then it's just the warfarin. And then she's also on a baby aspirin. Okay? Okay, last thing we're going to talk about. Last thing.
I have a question.
Yeah.
If you don't have the Doppler probe, is it impossible to auscultate the map?
It's hard hard to auscultate because what you're auscultating when you do it normally is you're auscultating the closing and the opening of the
I've
valve.
never seen that we have that.
I don't know, do they have one?
We don't think so.
If you guys want one, I'll bring you one the next time I come over.
We used to have one.
I think they're ultrasound.
The other in the room.
I think it's
There's lots of stuff here they haven't shown you yet.
If we do
Meaning
have
They
it.
might have one.
it, or,
Yeah, you might have it. So if you have it, or they might let you borrow it from I don't
that
know.
would be nice.
And if you need it, I'll bring you one. So all you have to do is call me, Michelle. We can't get it with the regular blood pressure cuff. I'll bring you one. Okay. All right. So now she's got a cord exiting the body. So anytime you got a cord exiting the body that communicates all the way up to the heart, obviously you have a big chance of infection, right? So the two big tenets of taking care of this, we call it the driveline exit site. The two kind of tenets of care are keeping it still or immobilized, right? Because the number one cause of infection that we see in our patients that get infected are usually what they do is that bag, they leave it on the table like that, and then they get up,
And start walking it somewhere.
right? And the bag, which is pretty heavy, drops and yanks really hard on this and tears. And this this skin, right? When it grows around the tube, it's strong. It's the strongest it'll ever be the first time it grows around. So then it's like a piece of tape that you keep like taking off the wall, taking off. It gets you know less and less strong every single time you take it off. So it does heal back after it rips like that, but it's never as strong. So what we try to do is keep it immobilized, which is why you see an anchor here, and we keep it covered and clean. Okay. So the dressing is called a driveline exit side dressing. We have kits. I just brought like 20 more kits to her bedside, so she'll come with them. And it's just like a central line dressing kit, okay, or a PICC line dressing kit. But it's specifically for the driveline, okay? So we make them and package them up, and this is what the patients and their families learn how to do when they go home. So I'm gonna show you how to do this. You're gonna have to be responsible for knowing that it's intact and it looks good. The daughter will usually come and do it, her daughter, the woman's daughter. If it hasn't been done, so it needs to be done every third day, so every 72 hours, the dressing needs to be changed. Or if like it ripped and it was oozing, or if it came undone, okay? Like any other dressing that you maintain, okay? So I'm gonna show you how to do it really quick, but you should know, I just want you to know when was the last time it was changed, when is it due, and has someone talked to her daughter's name is Kyla, and Kyla usually comes in and does it.
Does Kyla write the date on the dressing at all?
I don't know,
That'd be good.
but she communicates it with Lynn, and Lynn knows. Lynn
Okay.
knows when it's due. Okay. So this is a little backwards, right? Because her, it's just because I do it on both sides. But anyways, this is what it looks like. It's just on a red side and a left side. So you have your kit. You take your in the slides that I printed out for you, there is a website. There's a link to a website. It's a YouTube video of us doing the dressing online, so you can watch it. So this is just like a little trash can, okay? You put a mask on her. You put a mask on yourself. I'm not gonna wear it. Screw you guys.
Screw you, dummy.
These are just clean gloves, not sterile, so you just put your clean gloves, you've washed your hands, of course, you put your clean gloves on. I mean, really, this should take like 5 minutes. It's not gonna take that much time, okay? And what you're gonna do is, so first you're gonna take the anchor off, then you're gonna take the dressing off. So the anchor is just, it's like a Foley catheter anchor, okay? So it's got, right, so the way this anchor is working is there's a hole right here. You always know the hole is on the opposite side of the arrow, so this is the side that travels into the hole. Does that make sense? Right, okay, so to take it off, I just sort of open that hole up. Right. Pull that off, okay? So I pull that off. One thing, and it's the only thing that's not in order in the tray, is I like to use the alcohol swab to get it off. Right, so especially the anchor has the strongest adhesive. Right, so we do that, blah, 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 take the anchor off. Right, then it's shirt and pants, and so this is on the top, so I take the pants off first. And just, my mannequin just gets more and more sticky. But, I'm sorry, so the way it will come off on her is that's like a little come off in one piece. It won't rip like this one did, it just ripped because of the mannequin. Okay, so that's gonna come off. Then I go from the top because I don't wanna rip up against that skin. So then I go from the top, I take my alcohol, right? And then I come down. And take the dressing off. Alright, so then I take my clean gloves off. There's a pair of sterile gloves in there. And the sterile gloves are kind of overkill because it's not really a sterile site. Are you laughing? What are you laughing at? What's the problem?
When nurses stop moving, you know,
What?
if you can't stop moving, it's dangerous.
Yeah.
Especially if you got here 5:30, 36.
I have a 6-year-old boy, he's kind of like that too. Okay. Alright, chlorhexidine swab. There's 2 in the kit. I really usually don't need 2. And I don't do it if I don't need it because you think about how many times she's getting flogged with the chlorhexidine, you know? So anyways, it's the sponge wet every 3 days. So you wash, wash, wash. Hers doesn't have these sutures on there. This is how I train the family and the sutures are still on. So you can lift this up and go under, right? Don't be afraid. You're not gonna like go, oh bullshit, the fat came out, right? Like it's just not gonna happen. It's like really in there, right? So, right, okay. So, okay. So then you wash. The big thing here is that you let this dry, and of course the mannequin's gonna take forever to dry. So disregard this portion of this.
You're both wearing a mask, right?
Yeah, yeah. I'm just using my mask to wipe it off.
After sneezing.
Okay, but no, you let it fully dry. Really important that you let it dry, otherwise you trap that soap in there, right? Okay, now we took off the pants first and then put on the shirt. Now you're just gonna do opposite order. So here's the shirt, the back peels off, okay? And I want to get this exit site kind of in the lower portion of this.
The tail goes out the
Yep.
little hole thing.
Yep. So,
Pick line.
right, just like a pick line, okay? There's like little stabilizers here, so you're gonna try to get those on each side of the drive line. Okay? Then I take my pants. My pants I put in place before I take the backing off, just because it's a little unwieldy. Okay, shirt and pants, right?
I like it, that's,
I didn't- right?
cute way to say it.
Shirt and pants.
Thanks first.
Okay, you'll see the anchor, it's got this arrow on it, doesn't matter which way the arrow goes, the arrow's just there to tell you that's the side that's gonna
Down.
loop, yep. So same thing, I'm gonna put that, and I'm gonna put it all the way up like that. Okay, I'm not gonna have it like this.
Beyond the pants.
It's gonna be on the pantsuit, right? And then. Okay, and then I find my hole, see the hole? And then it locks in place.
It's a little tiny hole, right, maybe you just put it through.
What do you see?
I think it's hard to see the little hole.
Here goes.
When it's not through there, it doesn't really look like anything.
Yeah, it doesn't look like anything until you, okay. So, laying like that, you don't see anything.
Little tiny thing.
And you know the hole's gonna be on this side because the arrow is this side's traveling.
Ah,
Right,
it's
so-
opposite the arrow.
It shows you.
Everyone see the hole? Okay, find the hole?
Is there a little thing it's settled in, like the
I
pulley?
see it now.
There
Yeah,
is a little
like, little knob.
cavernous area.
Yep.
Cavernous area.
And you can see, like, it can move quite a bit now and not a lot of movement. Okay, so every 3 days, or as needed if it came ripped or undone or had drainage on it, okay?
And do we have a bunch of these on hand, I guess?
I just brought 20
Okay.
to her bedside yesterday.
60 days of changes. Okay, we're good.
20 times 3.
I know, 60.
So those are the contents of the dragline dressing tray. Like I said, in that packet, I printed all these, you guys can make a binder with those slides. There's a YouTube video link, okay? All right. I wanna do one more thing before you guys come up here and just practice the hands-on, is just go over like how you would organize your shift or your assessment of the patient. Like, so you're gonna receive her, right? Okay. So this is in the thing there, is you're gonna do, I would wanna know, one, just the VAD parameters. You're not gonna do much with this other than write them down, but the VAD parameters are okay. So on the face of this, you see 3 numbers, okay? One is the speed. The speed never changes, okay? The speed has been set in there by us. So the speed on this is 2640, right? Okay, what's the flow?
1.5 liters a
Right,
minute.
okay? And that's just because there's no resistance in this. So hers will be like 3.8, 2.5, right? Whatever it is, write it in, okay? And then there's a third number, and that's the power or the watts. That's how much electricity is it taking to spin at 2640 and give you however much it is. So speed, flow, watts, you can always get that information from this controller. There's nothing you can touch on here that will hurt anything or do anything. And I forgot to mention, if you push one of the soft keys, either the alarm silence or the scroll button, it'll backlight it. So if you're at night or you can't see, you can hit the button and it'll backlight the LCD display, okay? So your first thing you see here, right, what is your speed, flow, and power on the VAD? You're gonna auscultate the LVAD hum, that's how you, and that's just insurance for the future. Say something happened and you didn't know if the pump was on, if you've listened to that, you know what it sounds like and you know where to listen to it, right? You would never wanna listen to it for the first time when something's happening and you're like, I don't know, is that it? Is that it? Is that it? Right? Okay, you're gonna note, what source of electricity is she on? Is she on 2 batteries or is she on a battery in the AC? Right, when she comes up here, she's gonna be on 2 batteries, right? Alright, the driveline dressing change, when was the last time it was changed? I bet you $1 million those nurses didn't do it for you and it's due like tonight, right? And if it is, I'll do it for you. But I have a feeling it may have been done this
Are
way.
you gonna be here when she comes?
Well,
You said you're gonna
might, yeah.
Can change.
5, right? Okay, so you're gonna know when was the last time it was changed and does it need to be changed and does it need to be changed on your shift? That's right. Blood pressure, what was her blood pressure? Was her MAP under 90 and was her systolic under 100? Or was it over all of that and we're still treating her for hypertension, which is more likely the case, okay? INR, what was her INR? What was the last time the INR was taken and how much Coumadin is she taking, okay? And what are you gonna like ask whoever hospitalist you have if her INR is 1.8?
They wanna have love.
Are you bridging? Right, cause that's what, I mean, that's why like I'm wanting to talk to the hospitalist, is like I wanna make sure that they know what our protocols
Can you
are.
mail us this thing?
It's right there, buddy.
What?
In case I lose
I
it.
mean, I wanna have it.
Take a picture of it.
You mean like suggest to them below task protocol?
Or write it.
Oh, I have it, I'll give it to them,
Okay.
yeah.
Sometimes they don't know that kind of stuff.
I have a printed thing for them.
This is all.
And the what's her name, will have an electronic copy, my friend. Okay. Alright, backup bag. The backup bag must be with the patient at all times, okay? Yeah? Patients come all the time, they come to the clinic without their backup bag.
They have 2 bags,
Well, they have the bag they're wearing,
right?
and they have a backup bag. And what's in the backup bag?
Batteries, backup controller.
Backup controller and 2 fully charged batteries. So she's gonna go, I don't know if you guys had a therapy room, I don't know that you do, right? You're gonna take her down there with her bag, and you're gonna make sure you get 2 charged batteries and the backup controller. Okay, let's talk about things you absolutely cannot do. You cannot do chest compressions on her, right? And you wouldn't need to. You've got $85,000 worth of chest compressions right here, right? Well, what's the purpose of chest compressions?
To make the heart go.
85,000.
You're beating the heart, you're getting patient.
You're trying to get the blood moving, right? And if I have a pump that's doing like way better job of that than this, right? So first of all, there's no need, okay? Second of all, you're gonna dislodge the outflow graft by doing that. So we don't do chest compressions on bad patients. No MRI, not that you have one here, magnet, but she can have a CT scan or a chest x-ray or KB or any other thing. PET scan, nuclear med scan, she can have all that. Obviously, she can't be submerged in water, right? Because she's attached to electricity. She does have a shower bag, and I have taught the OTs on St. Mary's 4th floor acute rehab how to do that.
She can teach me.
So you can, yeah, so she's got a shower bag,
You have Lynn can with patient.
yeah. Okay, so she can shower. It's just that the electrical stuff has to be covered up, Yep, we're almost done.
Oh, great, I'll just let the doctor, I think there's only a couple of them.
That's fine, it'll only take a few minutes with them if they can give me about 10 more
And
minutes.
everyone said you are terrific, you're
We're so
doing a
good.
great
You
job,
are.
so
Very
thank you so
entertaining.
much.
Thanks for taking care of our patient. Obviously, you are not gonna disconnect both sides of the controller, the electricity, what's gonna happen? The pump will stop, right? You're not gonna take the drive line out of the controller, cause what would happen? The pump would stop, right? So you're not gonna do those things, right? They have to have that backup bag with them, no matter what. If they leave the room, they need the backup bag, okay? And when she is sleeping at night, she needs to be plugged into the AC adapter. That way no one has to, cause I'll tell you what, on a busy unit where I don't know how many rooms you have on one side, but you could easily not hear her battery alarms, right? And they could escalate, right? So if she's going to sleep, she needs to be on AC. How can you tell if she's on AC? Plug, right? Or just follow the battery, right? Right, so the reason why I showed you the bag is because the bag makes it like, I don't know what it is about us, but like when we're digging through people's personal space, we don't want to like really get in there. But I want you to do it so you know like where's this going?
Yeah.
Where's it going back to? Like, you know, be that person that does that so that you're taking good care of her, okay? Okay, defibrillation and cardioversion are safe. No problem. If whatever reason you felt like she was hemodynamically unstable and someone put her for whatever reason on an EKG machine and she was in VTAC, I'll tell you two things. One, she will be hemodynamically stable in VTAC. You and I, VTAC, 120, 220, whatever the rate is, boom, I'm on the floor, you guys are calling a code, right? I can't sustain VTAC. She can, why can she? Right? She will slowly decompensate. I will VTAC, right? She will VTAC for hours to days and slowly go into shock and die. VT untreated for a long period of time, or VFib even. So I've seen patients awake and talking and yelling at me in VFib. So it's just not as, so you guys worry about it, and I'm just telling you, like, so she might be in it.
Yeah.
she'll be stable enough for you guys to move her.
Is she on telly?
No.
No.
No. So I'm not gonna go into a great amount of detail there. I'm gonna say if she needed to be shocked, it's safe to shock her. You don't have to do anything with this equipment. It will not like arc or like, you know, short. So she is safe to shock her if you need to shock her, okay? Okay, so for any VAD alarm, so you're only gonna get certain kind of alarms, like if you disconnect, eventually you'll get an alarm here, right? So you should just be experiencing alarms that are episodic, that come and go because you've done something to it, right? If you have any alarm that you don't know why it's alarming, it won't go away, you page the 24-hour, so there's only 4 of us, we all rotate carrying this pager. So it'll be one of the 4 of us. So 24-hour, 365 days a year pager that one of the 4 of us answers, okay? Now, that's if you have an alarm, if you have an emergency, if there's something you need to talk to someone right this second, right? If it's Monday through Friday, I don't know, they call me on Saturday. You know, you can call me anytime, basically. So my cell number is in this thing, it's on all the printed stuff, you have my card, you can call and ask me questions, but just know that if I'm doing something like this, I may not call you back for an hour, right? Okay. So if you need to talk to someone right away, what do? Page 443 LVAD or 5823. Okay. Really simple steps. If you think the VAD is off, right, someone's going to be calling MCS, the pager, and you're going to check the drive line and check the electricity. If they're off, you're going to put them back on. Okay, what if you've done all that and the VAD is still off? You only have one thing left to do. Change the controller. You can do that.
I think this one.
Yeah, thank you. All right. So let's get all our cords straight so you know exactly what we're dealing with here. Okay, I'm gonna let you hold that like you're the patient.
A mess. So many ways.
Okay. If this isn't working and I've checked the drive line and I've checked the electricity and it's still not working, I'm gonna take out my extra one. And what do you think I have to put on my extra one before I move the drag line over? Battery! Right, so all I do, and it doesn't matter which one I take, I just take one source of electricity. As soon as, you can tell me when, as soon as I see the light go on, light on, I can take, just to do this real quick. This drag line out, and put it in here. Okay,
Got one on,
so it was off for 10 seconds, 8 seconds,
2 seconds.
right, and now it wants,
Put your wall.
right. Okay, the chances of you having to do that are so low. I just can't even imagine that her, like I said, it just like, this stuff just doesn't quit like that. More often it would be because like someone turned both sides of electricity off, and what do? Put it back on. Right? Alright, so again, to change a controller, I get my new controller, I set it there, okay? I take a source of power, any source of power, doesn't matter what it is, and I put it on the controller. By putting electricity on the controller, it's gonna wake the controller up. When it's awake, I take the drive line out of the old one and put it in the new one. Okay? Starts back up. Does that make sense? Alright, has everyone put a battery on and put the drive line in? Okay, does everyone feel comfortable with that?
I need to feel comfortable
Okay.
because I'm not the patient.
Alright. Thank you for your time and attention. Any other questions? Okay.
My God, right here.
That's gonna alarm when you, oh wait, here. Actually,
Michelle,
do
is
this.
that, since, is this more nursing oriented stuff?
Yeah, the stuff I do with you guys are, yeah, nurse.
Okay.
The doctor stuff's gonna be more advanced, like what meds they should.
Thank you very much.
You're welcome.
Appreciate it.